I am here with my colleagues Stephen Blake, Erin Murphy, and Efthymios Avgerinos to talk about STEVECO trial and the future of venous stenting. We are here to talk about the STEVECO trial, which was a prospective randomized multi-center 12-month trial comparing venous stenting using optimate sinus venous versus conservative treatment. The trial measured disease-specific quality of life, venous clinical severity score, and patency in 63 patients who had either post-thrombotic syndrome or nivels. The results showed the symptomatic patients with deep venous obstruction who received the sinus venous dedicated venous stent had significantly improvement in veins quality of life, veins SIM after 12 months, but also a significant improvement in VCSS and pain disability index. Steve, what is needed as next step for bringing more evidence to the venous stenting field?
Houman, that's a great question. I mean, obviously, you guys are to be congratulated on performing this trial because there has been no randomized data in the chronic space before STEVECO, and I know the difficulties you had with running it. So we need randomized data of some description, whether it's trials like this. We need bigger registry data, and obviously we're working on a project with the European Society of Vascular Surgery and CSA to set up a European registry. And there are also some other options for large data collection using causal inference, which is a methodology to compare groups of patients without having to randomize. So I think the simple answer is we just need to establish more robust databases to support the therapies that we are trying to offer patients.
So my next question goes to Professor Avgerinos from Athens. Dear Makis, what about Europe-wide efforts in terms of registries to augment the evidence base for venous stenting? Steve already mentioned the registry. Maybe you can...
Right. I think Steve already mentioned it. It's an exciting time for the venous world. It's an exciting time for ESVS as we are launching, under the leadership of Steve Black and Rob Hinchcliffe, the ESVS Venous Registry. We're going to get the main centers all around Europe to start entering data on deep venous intervention.
Makis, please elaborate on the ESVS guideline on venous stenting and how the STEVECO trial results have influenced this and any other additional evidence needed.
So the most recent ESVS guidelines on chronic venous disease were published in 2022. That was just a little before the STEVECO trial came out. So they do not include STEVECO trial. So the guidelines right now include the fact that we can stent patients with iliac vein outflow obstruction when they have severe symptoms. This is grade 2A and level of evidence B because we only have like a small series, a very small randomized trial, retrospective studies. Now adding STEVECO on top of what we already know, I think this can upgrade the level of evidence from B to A. And this really supports the role of stenting, and I think this will embark a new era in the management of patients with post-thrombotic syndrome.
Since STEVECO trial struggled with recruitment, so we discussed about it, what could be done better in the future? Erin.
You know, Houman, I think that, it's a little difficult, as we've seen across the trials, ATTRACT, C-TRACT, now STEVECO, to recruit into these randomized controlled trials. I think part of it is that we're asking questions that, yes, people like to have higher grades of evidence, but we really know the answers to these, right? We have 5 IDE trials. We now have STEVECO data that show us that venous stenting works, and it works across patient subgroups, and it's, quality of life improves across the board, and so does venous functional outcomes. So I think, honestly, what we need next is trials that focus on real-world data across specialties treating these patients, giving us, more information on which patients and which groups actually benefit more specifically using your classification schemes and these specific groups. I think that'll help with recruitment.
And Steve, what is your idea about that?
Every single trial in the venous space. We know that C-Track has struggled to recruit in the US and is behind schedule on enrollment. In the UK, we tried to run a trial called BEST PTS, and that has to be suspended because of recruitment problems. We're going to restart the trial now, but we've had to significantly revise the recruitment targets. Typically patients who are trying to enroll in these studies want treatment. So the conversation with the patient is extremely difficult, and we have to try and work out how we will frame that conversation around equipoise if we want to run randomized control trials. So probably the way to address recruitment is to look at novel trial designs that do not involve randomization of patients, to try and get everybody into some form of prospective data collection.
Makis, could you comment on patient selection?
Obviously, not all patients with PTS are the same. There are different anatomies and different outcomes. And eventually, it only depends on the inflow. Do you have the femoral vein? Do you have the deep femoral vein? Do you have both open? So based on your classification, we know that patients who don't have good inflow, who don't have a femoral vein inflow or a deep femoral vein inflow, they're unlikely to do well with a venous stent. While patients who have good inflow from the femoral and the deep femoral vein will probably do best. So we need to look back at our data, maybe validate your classification, looking at the STEVECO trial, and see which patients do best. And from now on, prospectively, in our registries, in our trials, we need to implement this anatomic classification to see which subgroup of patients actually do best, so we can better communicate and we can better compare the results between trials.
And Erin, would you like please to comment also on this patient selection?
Yeah, I think it's extremely valuable to be reporting in a little bit more detail on these patients using your classification. And I think to your point that you just made, we need to make sure we're standardizing what we're collecting across the trials, right? Like we look at those IDE trials we talked about yesterday, and they looked at different patient groups. They thought they were looking at the same thing, PTS, SNVL, but they all defined differently across the trials. Different patient outcome scoring systems are used, right? We need to have the same outcomes across the board. And I think, Steve, you've done some work to make sure that we're headed in that direction.
I think both of you have made important points about standardization. It's been very difficult to compare the IDE studies, as you've highlighted in several talks, Erin, because the trials were set up in a different way, the outcome measures were different, and the way we classified disease was different. So I hope that we can get to a more standardized approach. We've been trying on several different fronts to make sure that people are reporting to standard outcome measure. That drives a difference. And Houman, your work on the classification was really important to allow us to have some form of anatomical basis for putting patients into buckets that could be compared, because I think that's a big driver of success in stenting.
Makis, can you please explain us how technical tools can help us for patient selection?
Right, as we just discussed, we really need to know the anatomy. So to be well prepared to intervene and better communicate with our patients, we need to have good imaging. And in today's practice, I think imaging techniques have evolved. Some institutions like yours or yours, Erin, do excellent MRVs. My institution can give you an excellent CT venogram. But stepping back, a good ultrasound will give you all the basic information that you need to properly assess the inflow. Eventually, we will all end up with IVUS. IVUS is necessary to better understand the inflow and the outflow to optimize the stenting outcomes. So combining all this together, duplex, axial imaging, and IVUS, you can better decide which patients will benefit the most, and you can better predict what the outcome of your procedure is going to be.
Erin?
Yeah, I couldn't agree more. I get the same sort of imaging in my patients with axial imaging, very high quality duplex. It takes me almost a year to get a good trained ultrasound tech in Venous, and I think we need to make sure that that's a more universal training across, specialists, ultrasound specialists. I would say also IVUS is essential, but also duplex in the role of post-operative management, right?
Yeah, I mean, Houman, you touch again on aspects of all the trials that need to be optimized. If we do a trial of a technique that involves technical skill, ability, and a learning curve, and don't do it when people have optimized how they deliver that treatment, you're going to get a trial of a poor intervention against doing nothing, which is unlikely to give an outcome that is beneficial to patients or us. So utilizing all the available things we have to make sure that we perform the procedure to the best we can. And we know from STEVCO, we know from ATRAC, we know from the CAVA study that technical success delivers optimal outcomes for the patients. And if we don't get that right, we are going to have problems.
So maybe this question goes also to you all. How do we make sure to provide the best long-term treatment, since we are treating a lot of young patients? So maybe we start with...
Yeah, I mean, Houman, it's again a great question. It's been a significant issue for venous disease. Our patients typically are much younger. In the context of female patients, of which are high proportion, they need to have something that is durable not only through their lifespan, but potentially through pregnancy and having children and so forth. So I think we need to see that long-term durability data for these treatments, and of course we can only get that once things have been in people for a long time, so some of it has to be predicted. But I think we also have to work on the things that we've forgotten about in the drama around what is the next stent. So we need to maintain stents in patients and look after them. So that comes with better drug therapy, potentially innovation around technologies that help us to look after stents for the lifetime of a patient. And we need to optimize the implantation phase of that stent, which, like we've seen in peripheral arterial disease, coronary disease, and so forth, had an evolution of technology to support the initial procedure being better to sustain long-term outcomes.
Erin, maybe short comment.
Sure. It's simple as technology, which we're advancing. It's technique, which we know that technical errors contribute to stent failures as a number one. It's surveillance and anticoagulation management, right? And it's learning from our mistakes, and it's education, because there's still so much to do in the venous field.
So you mentioned anticoagulation, Makis. Maybe you can comment on it. Do you think the patient selection pre-operatively will also affect someday our anticoagulation regimen in order to improve the outcome?
From what we know now, we don't have great data regarding anticoagulation, but from what we now know, it seems that low molecular weight heparin with its anti-inflammatory effects may be beneficial in the early period after placing a stent, and then DOACs will do the job. However, I want a little bit to expand on what Steve and Erin have already discussed. It's really going beyond just the perfect procedure. We need to embrace the patient with a multidisciplinary team, following up closely, providing best medical treatment, checking on the compliance of the patients on anticoagulation, having hematologists around, compression specialists, and so on, to guarantee the best long-term outcome.
From now those comments, I can say then those procedures should be centralized, right? What do you think?
It's always an emotional question, that Houman. People who want to do procedures always feel agitated about being told they can't do procedures. But I think the truth in the middle of that is, to Erin's point about technical failure being at the heart of procedural failure, is you have to do enough and do them often enough to become good, and that's in the best interest of patients. So that may be centralization or centers of excellence, and hopefully the data that we're all generating can support that narrative, as it has done for aortic surgery in the past.
So many thanks to you, Steve, Erin, and Makis for this recording. I think we could end now our conversation here. I think with STEVECO trial, we did one correct step toward better treatment and outcome for those patients.